Hello everybody, hope you all are fine. Today we are going to start the part 2 of a typical synovial giant. So at the end of this session, the participant should be able to describe the remaining components of a synovial giant that is ligaments, articular fat, articular disc and menisci. Explain neurovascular supply of a synovial giant. Describe the factors stabilizing a synovial giant and correlate different clinical implications such as osteoarthritis and synostosis. First, we start with the ligaments. These are the thickened, regular, and interlacing bundles of collagen fibers. They are non-stretchable but pliant. That is, they do not hinder the normal actions or movements. They remain taut within the range of a particular movement. They are designed to check excessive or abnormal movements. They protect the excessive stretching of the related muscles. They are divided into intrinsic and extrinsic groups. The intrinsic ligaments are part of a capsule such as glenohumeral ligament, which are seen on the inner aspect of the shoulder joint capsule after opening it. Second group is the extrinsic or accessory ligaments. Extrinsic or accessory ligaments are not part of the capsule and they stand clear of the capsule but reinforce it. They are frequently represented by extension of the related tendons. They strengthen the joint and prevent abnormal movements. They are divided into two groups, extracapsular and intracapsular ligaments. The extracapsular ligaments stand outside the capsule and are separated from it. They are the true binding force between the bones forming a joint. Example are the collateral ligaments of the knee. Second group is the intracapsular ligaments. They lie inside the capsule but are separated clearly from it. They lie in a space between capsule and synovial joint, and the example is the cruciate ligament of the knee joint. Articular pads of fat and intra-articular discs. First, the articular pad of fats or adipose tissue pads. They are present between the synovial membrane and the fibrous capsule. They are flexible, elastic, and displaceable packing material, which fills the spaces or gaps which appear between the bone or articulating bones during movements. They increase the surface area of the synovial membrane and promote distribution of synovial fluid, hence facilitate movements. The intra-articular discs and their general features. These are sheets of white fibrocartilage in certain joints such as temporomandibular joint. These discs are avascular except their peripheral parts, which are attached to the capsule and get vascularity from the capsule. Their central part get nutrition from the synovial fluid. They have got no innervation, hence are insensitive. As regard their functions, they divide the joint cavity into different compartments which help increase mobility during different movements. They, as they are accessory ligaments, they strengthen the joints. They are protective in nature as they minimize erosion of the articular surfaces. They enhance the congruence of articular surface by deepening these surfaces. They act as shock absorber as the fibrocartilage is compressible. The types are: number one is articular menisci. These are crescent-shaped or incomplete rim-like structures which are thin in the center and triangular on cross-section. Hence, they deepen an articular surface and increase the contact between the articular surface, providing more stability. Their peripheral parts are attached to the capsule, hence divide joint cavity into two spaces or giant spaces which have got different types of movements. As the cartilages are translucent, so spaces appear between the bones, forming a joint on X-ray, such as is seen in case of bones forming the knee joint. Number two is articular labra. These are in the shape of a fibrocartilaginous annular rim, which is triangular on cross section. Articular labra are attached to the articular surface one of the bone which form the joint, such as scapula and hip bone. They deepen the articular surface, hence enhance the stability. They are avascular except their peripheral parts. They provide lubrication, hence facilitate the movements. Number three, articular discs. These are plates or rings of fibrocartilage which are attached at periphery to the joint capsule and separate the articular surfaces, sometimes completely, into upper and lower joint spaces. Hence, serve to adapt articular surfaces. These are seen in temporomandibular joint and sternoclavicular joints. Blood supply, lymphatic drainage, and innervation of a typical synovial joint. First, the arteries. Arteries usually form a network, the periarticular vascular plexus, around the joint in the shape of a vascular rete, which is formed by regional artery branches. The branches from this rete pass through joint capsule and reach the subintimal tissue, where they form another plexus which feed the synovial tissue. A minor trauma to the joint may rupture vessels of this subintimal plexus of arteries, hence lead to hemarthrosis. As regards the veins, veins follow the pattern of arteries and drain into larger veins. Arteriovenous anastomoses are also present in the subintimal tissue of synovial membrane. As regards the lymphatic drainage, subintimal plexus present in the subintimal area is made up of lymph vessels which drain into lymph node usually present on the flexor aspect of the joint. As regard the innervation, one must remember Hilton's law, which states that trunk of a nerve sends branches not only to a particular muscle but also to the joint moved by that particular muscle and to the skin overlying insertion of that particular muscle. The sensory end organs are present in the capsule, ligaments, and synovial membrane, and these are free nerve endings for pain and raffinase corpuscles for proprioception. This diagram depicts mobility of a particular joint versus stability of that very joint. If we critically analyze this diagram, we come to the conclusion that the most immovable joints, such as sutures, are the most stable joints, whereas on the other hand, the most mobile joints, such as shoulder joint, is a very unstable joint. Now we come on to the factors stabilizing a typical synovial joint. First are the main factors. Among them, first one, muscles that cross a joint play a major role in the stability of the joint. Example is that arches of the foot collapse, hence flat foot, if long and short muscles of the foot becomes lax. Number two, ligaments. They prevent overstretching and provide protection against sudden stresses. Examples are cruciate ligament. But continuous stress lead to stretching of the ligament, hence they become less important. Number three, the articular surfaces. They play a role in the stability depending upon their shape, size, and arrangement, as is more obvious in hip joints and least important in knee and shoulder joints. After the main factors, now the additional factors stabilizing a joint. First, the tendons. The tendons, which are intimately related to a joint, play a significant role, such as tendons of the brachii, biceps brachii in shoulder joint. Number two, additional factor are the articular discs, menisci or labra. They increase the intimate contact between the articular surfaces, hence provide better interlocking. Number three, flexor surfaces containing soft tissue limit the flexion at a joint. Number four, in close packed position, there is full congruence of the articular surfaces, which make the joint more rigid, as seen in locking of the knee joint. A mutual attractive force generated by a thin layer of synovial fluid may play a minor role in the stability of synovial joint. Similarly, atmospheric pressure may play a minor role in the stability of a synovial joint. In applied anatomy, the arthritis, any disorder that affect the joint is named as arthritis. General symptoms which the patient complains are joint pains and stiffness, but it may include redness, warmth, swelling, and decreased range of movements at a joint. There are two main types: osteoarthritis or osteoarthrosis, which is because of degenerative process, and rheumatoid arthritis, which is because of autoimmune process. Second is the synostosis. It is fusion of the opposed articular surface of a joint which occurs with increasing age. Synostosis is seen in almost all types of joints, such as sutures of the skull, the example of fibrous joints, symphysis pubis, the cartilaginous joint, and sacroiliac joint, the synovial joint. Now let us have a look at the osteoarthritis or osteoarthrosis. As earlier said, is a degenerative or erosive process that involves the articular cartilage initially but leads to changes in the bone as well. In osteoarthritis, articular cartilage becomes soft and thin, leading to exposure of the underlying bone. This exposed bone under stress leads to hyperostosis, that is bone outgrowths, as marginal osteophytes or spurs. The patient may complain having discomfort, pain, stiffness, and loss of function in the affected joint. Osteoarthritis may lead to inflammation with exaggerated misery in the affected joint. Osteoarthritis usually occurs in weight-bearing joints in old age and especially in the obese persons. On X-ray, we see lipping of the bones because of bony spurs or osteocytes. In addition, there is reduced joint space, which indicate reduced thickness of the cartilage between the bones. The rheumatoid arthritis is a chronic autoimmune disease in which immune system of the body attacks its own tissue, primarily the small joints of the body. In rheumatoid arthritis, the activated leukocytes of the immune system infiltrate the synovial membrane and cause hyperplasia and inflammation, which leads to progressive destruction of the cartilage and bone, which ultimately culminates in deformity of the small joints. These signs and symptoms of the rheumatoid arthritis are pain, swelling, and stiffness initially in the small joints of the hand with redness, warmth, and loss of functions. The risk factors include smoking, obesity, and pollution. Women and older peoples are more likely to develop rheumatoid arthritis. X-ray findings show number one, periarticular soft tissue swelling, which is because of the combination of joint effusion, edema, and tenosynovitis. There is symmetrical joint space loss because of cartilage degeneration. Third, there is decreased bone density because of decreased calcium deposition. Number four, in advanced cases, deformity in the shape of dislocation and destruction of the joint may occur. Treatment includes anti-inflammatory drugs, physical therapy, exercises, education of the patient, and surgery for deformity if needed. Comments and suggestions will be welcomed. Thank you for listening and watching.